Well, good evening and welcome everyone. Thank you so much for joining us for another Wellness Webinar Series event with Jefferson Health. My name is Sarah Breckbill and I'll be serving as your program facilitator and will present your questions to our panel of experts tonight. This evening, we'll hear from experts in gynecology and primary care to talk about all things menopause, from managing symptoms to treatment options to perimenopause, hormone therapy, and more. We've got you covered. Well, thank you so much for submitting your questions in advance, and we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. We actually received over 300 questions, so thank you. You will also have the option to ask questions during the webinar. And due to hospital guidelines and privacy, please note that we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, including Dr. Robin Fay, Dr. Julia Switzer, Dr. Jessica Clemens, and Dr. Sandra Rapp. Well, thank you so much for joining us. I know we have a lot of questions to get to, clearly. But first, I will give each of you a minute or two to just say hello, provide a little background information about yourself, and then we can get into the discussion for tonight. So Dr. Fay, we'll go ahead and start with you.
Thank you so much for having us tonight. I'm so glad everybody's here. I am a certified OBGYN. I transitioned to just gynecology, and I do menopause, I do sexual health, pelvic pain, and dermatology. I'm a certified menopause practitioner, and I also chaired the Consumer Education Department at the Menopause Society. I was the second physician in the state of Pennsylvania to actually be certified in sexual health, and so I also do sex counseling. And I believe everyone is entitled to a healthy, painless sex life. I teach residents, nursing students, and PA students, and I love to care for women in all stages of life, from young to mature, and help patients dealing with menopause, sexual health, and to support cancer survivors to achieve sexual wellness.
Amazing. Thank you so much. We're so excited to have you. All right, let's move on to Dr. Switzer. How are you doing this evening?
Good evening. Thank you for having me. I'm delighted to be here and with my colleagues to talk about this important topic. I am a general OBGYN. I practice full scope OBGYN at this time in Center City. My clinical practice is at the Navy Yard in South Philadelphia. I'm also the residency program director at Thomas Jefferson University Hospital. And I became a menopause certified provider because I recognize a huge gap in the training for our younger faculty and trainees. And in fact, that's supported by the literature that really only 30% of OBGYN residency programs has an established menopause curriculum. And I wanted to be able to train my residents and ensure that the women here in Philadelphia, and as our residents go on to their next steps throughout the country, are able to provide this such important care to patients as they continue in their careers. So I'm delighted to be here tonight and to talk about this with all of you.
Absolutely. We're delighted to have you. So thank you. Okay, and next, Dr. Rapp, how are you?
I'm good. How are you? So good to see everybody here tonight and do another one of these webinars and spread the information out to the public. And my name is Sandy Rapp. I'm an OBGYN. I practice at Women Care. I've been there for 25 years. We have offices in Abington and also in Willow Grove, and I can also see patients virtually, both in Pennsylvania and in New Jersey. I'm a Menopause Society certified practitioner. And have been, in practice now 25 years, seeing lots of menopause patients even before that. And I do have, I don't deliver anymore, but I have a focus on menopause and perimenopause in my practice.
All right, well, thank you. And last but not least, Dr. Clemens.
Hi, thanks for having me as well. I'm actually following one of my senior partners, Sandy Rapp. I'm also in the women care practice up at Abington, and we have offices here at the hospital as well as out in Willow Grove. And I've been a general OBGYN practicing, I guess, nearly 20 years now. I, still do full scope, similar to what Julia was talking about, which means that I do OB in the office. I still deliver babies and do obstetric care in the hospital, as well as I do GYN in the office, as well as GYN surgery. I do a fair amount of GYN surgery, focus on minimally invasive surgery like advanced laparoscopies and robotic surgery as well. In the last couple years ago, decided to go ahead and get the certification for the menopause through the Menopause Society. I have been treating these patients all along, but I do appreciate, the additional certification and the push to really keep up with the continuing medical education and really feeling more confident to provide, the most up-to-date and evidence-based medical care to our patients. So thanks for having me.
Absolutely. Thank you for being here. Okay, and with that, I say let's go ahead and dive into the questions because I know we have a lot to get to. So for the first question this evening, Dr. Fay, we will have you start and kick us off. First question, what are the treatment options for menopausal hormone therapy? And can you talk about the pros and the cons? Oh, and I think you're on mute.
I'm sorry.
All
All
good.
right. Am I off mute now?
I can hear you.
Okay. When we talk about menopause hormone therapy, we're referring to either estrogen therapy or estrogen and progestogen therapy. So sometimes we discuss these options, and it depends on whether the woman has a uterus, her age, and it should be within the 10-year window since her last period, and her risk profile. Estrogen therapy is for a woman who's had either a hysterectomy or a hormonal IUD within the first 5 years of use. And the forms that can be used are either an oral tablet, a transdermal patch, gels, sprays, and then we also talk about, for other options, a vaginal cream, ring, tablet, and insert, which we will talk about later in our discussions. The pros: estrogen is most effective for hot flashes, night sweats, sleep disturbances. It protects against the bone loss and reduces fracture risk. It also improves our quality of life, moods, and also joint pain, and which we will talk about later. And I think Dr. Rapp is going to talk more about is vaginal estrogen, which improves vaginal dryness, decreases the risk of urinary tract infections, and genitourinary symptoms. The cons: if the uterus is present, just using estrogen alone increases endometrial cancer risk. So we have to use a progestogen, and that must be added. And that's why that would talk about either with the IUD or just using a progestogen. And we now most often use an oral prometrium, which is actually a more bioidentical or a more easier but progesterone to use. Oral forms have higher risk. Now, this is talking of estrogen again, has higher risk of blood clots, stroke, and possible gallbladder disease. Breast cancer has not been increased if you use estrogen only, and that has been by multiple studies. Combined estrogen progestogen is for women who have a uterus, and that's with women who, again, with talking with their doctor alone. You can either use it by continuous daily or you can use it cyclical by using just the progestogen. The estrogen is used every day and the progestogen is cyclical. And again, this is discussed with your practitioner. The pros: the same benefits of the estrogen as we talked about for bone and vaginal health. It protects the endometrium from estrogen-related cancers of the endometrium. The cons: there's slightly increased risk of breast cancer with long-term use, and that's greater use of 3 to 5 years, and that's what the studies show. There's higher risk of venous thromboembolic disease and stroke with the oral route, and that is why now, after multiple studies, we are now suggesting to women to use the transdermal estrogen patch versus oral estrogen. If you use the estrogen progesterone, there can be some irregular bleeding, there can be some breast tenderness, there can be some mood changes. So all of this, trying not to confuse people, to sum up the pros: the most effective treatment for hot flashes and night sweats, improving sleep, mood, vaginal health, and urinary health, preventing bone health and fractures. It may lower your risk of diabetes, and it may lower your risk of colon cancer. Is hormone therapy. The cons: if it's taken orally, may increase your risk of stroke, clotting, and gallbladder risk. Combined, there might be a small increased risk of breast cancer with long-term use. So the general rule, if you are a good candidate, healthy women less than age 60 or 10 years from your last period, so that's that 10-year window that we will be talking about, with bothersome vasomotor symptoms or other symptoms that you will discuss with your practitioner, you are a good candidate to discuss with your practitioner hormone therapy. You are to avoid systemic therapy in women who have history of breast cancer, unexplained vaginal bleeding, prior clot, stroke, or severe liver disease. And we'll be discussing a lot more during this. But the bottom line is that in 2025, hormone therapy, menopausal hormone therapy, which it is now called, it's no longer called hormone replacement, is for quality of life issues.
Okay, thank you. I think that was a really great high-level overview to kick us off for the evening. So appreciate you walking us through that. All right. Well, for our next question here, now I want to turn it over to Dr. Switzer. Dr. Switzer, how can one manage or minimize weight gain during menopause?
This is such a common question that I get in my office. And we're going to talk a little bit more later about perimenopause versus menopause. But the important thing to know here is that this is a big transition time in the lifespan of a woman. And there's so much that's changing in the body. One of the things that people complain a lot about is weight gain, particularly weight that accumulates in the middle. We call this central adiposity sometimes, and it kind of gets stored right there, right above your waistline. This is frustrating for women because they may not have changed anything that they do in their life. They haven't changed their diet, they haven't changed their exercise regimen, but they're starting to notice that the weight just sticks there and it doesn't go away. This happens for two reasons. One is age. This is just a natural part of aging in humans. And, I like to tell my patients, if you look at men in the same age group, we're seeing that central adiposity grow as well. There just isn't quite so much societal pressure on them for that weight. So there's age, that's certainly part of it. And there's also hormonal changes. So as our estrogen declines in perimenopause and after menopause, we start to store more fat there. And I'm convinced that it's some sort of evolutionary survival strategy to keep us warm and protected. But also what's happening is that we're losing our muscle mass. So for women after age of 30, actually, we're starting to slowly lose muscle mass, and that can accelerate in the perimenopause and after menopause. Muscle mass actually uses more energy even when you're at rest. So the more muscle you have, the more that you're burning calories, even if you're not doing anything. So this is the part where I think people need to understand that even though you haven't changed anything, your body is changing as a result of age and your hormones, and the composition of your body just isn't using your calories the same way that it did in the past. So really it's time to reframe your thinking about your health and your longevity. Menopause and perimenopause is a really great time to start thinking about how to keep yourself healthy for the long term. So the best things to do are to focus on a healthy, well-rounded diet. And usually we recommend a Mediterranean diet, which is full of fruits, vegetables, fiber, protein, and good fats, healthy fats, as well as fiber. And then to ensure that you're getting enough exercise. And this is really hard, especially for women in their 40s and 50s who may be in the accelerating or the peak of their careers. They're busy with their families, their friends, aging parents. It's very hard to focus on your own health. We recommend about 150 minutes of moderate intensity exercise a week, which can seem really overwhelming. But if you cut it down into small chunks, so 20 minutes a day, brisk walking, taking the stairs in between, if you're sitting at a desk for most of your workday, making sure you're getting up for a few minutes each day to take some laps around the office or walk out for lunch. These are things that are going to really help you maintain your weight and, most important, your health and longevity for the long term. I think on average, women without attention to this can gain about 20 pounds during this menopausal transition just as a result of age and hormonal changes. So perimenopause and menopause is a great time to really start establishing good habits or diet, exercise, and focusing on your own health.
Okay, thank you. Appreciate you walking us through that. I think that was really helpful. All right, we will go to Dr. Rapp now, talking a little bit about joint pain. So is joint pain a normal symptom of menopause?
Yeah, so the short answer is yes, it absolutely can be. And it's not just joints, it's muscles. We've heard talk about it's called the musculoskeletal syndrome of menopause. But the longer answer is like a lot of things that occur at this time of life, it can be from a variety of factors. First of all, it is very common in menopausal age women to have musculoskeletal pain. More than half of women will have this as one of their symptoms. Part of the history is it's important to determine, is it joints? Is it muscles? Is it both? Things like new onset joint pain can be from certain types of arthritis or something called rheumatoid arthritis, which is important not to miss that. Muscle pain can be from different medications, such as statins that women are on at this time in life, can be from other medical conditions like fibromyalgia, like vitamin D deficiency, like thyroid deficiency. Women that have had breast cancer are very commonly on something called aromatase inhibitors. You might have heard of these. Common ones are anastrozole or letrozole. And when you think that the whole purpose of those medications is to try to get rid of as much estrogen as possible, musculoskeletal pain is a very common symptom from those medications. So it makes sense that it's really from a lack of estrogen. So while this is not typically a sole indication for hormone therapy, it's often part of a constellation of symptoms, and we do often see that it can improve with hormone therapy.
Okay, thank you. Definitely a lot of considerations to think through. Okay. Next question here, Dr. Clemens, we will turn to you. Is chest pain a possible side effect of the estradiol patch or just a coincidence?
So I'd like to start off by saying that coronary heart disease is a relatively uncommon occurrence in premenopausal women, but there's a sharp increase in this scenario after menopause. So chest pain at any time should be reported straight away to your primary care, or could be evaluated directly in the emergency room. Chest pain is not a side effect of estradiol patches. However, it should be evaluated, especially in people if you have underlying cardiovascular risks, like say you have high blood pressure, you have high cholesterol, or diabetes that would put you at more risk. In women with no cardiovascular risks who start menopause therapy shortly after menopause, it has been shown in studies that they do not have increased adverse effects when they're evaluated. There's the KEEP study when they evaluated them in 4 years, and then again 10 years later at 14 years out. KEEP study is the Chronos Early Estrogen Prevention Study, acronym KEEPS. It's a randomized, double-blind, placebo-controlled trial for hormone replacement, which is like the gold standard of types of studies to look at. This study wanted to test the hypothesis that hormone therapy administered to recently postmenopausal women, which they said was 3 years, within 3 years of menopause, with good cardiovascular health to start, would slow the progression of atherosclerosis. Atherosclerosis is the deposit of cholesterol or fats or other substances within your arteries. So the KEEP study had a continuation study, as I was saying, for 10 years, even beyond that initial 4 years. And that was aimed to determine the long-term cardiometabolic effects of hormone therapies initiated within that 3 years of menopause. These same participants in the initial study were also in the continuation study. This study showed no evidence of cardiovascular or metabolic effects or adverse effects associated with the use of the oral or transdermal forms of hormone therapy in these recently menopausal women with good cardiovascular health from the start. So still the long and short of it is if you have a new onset of chest pain, you shouldn't poo-poo it and think, oh, it's just part of menopause. Maybe it's just a side effect of this new medication. It really should be evaluated properly by a physician or within an emergency room setting.
Okay, thank you. Yeah, an important call out. Always talk to your physician. So thank you. Okay, we will turn back to Dr. Fay now, talking a little bit about hormone therapy. Is menopausal hormone therapy dangerous for overweight women?
No. Being overweight or obese does not affect the risk profile for menopausal hormone therapy. The route of delivery and the individual woman's health risk is really all that matters. So being overweight or obese increases your baseline risk of venous thromboembolic disease or having a pulmonary embolus or stroke. Oral estrogen increases the risk of clotting by going through the liver first. And so therefore, that might not be the best option for somebody. So it's better to do transdermal because that decreases the risk of clotting by bypassing the liver. Cardiovascular health for everyone should be evaluated. So if somebody is, whether they're thin or having problems with their weight, that should be evaluated. And somebody who is overweight also has blood pressure problems, so that should be evaluated. We always are concerned in terms of their risk profile, so they need to fit into the right age profile in terms of less than 60 within that 10-year window. And we talk about transdermal estrogen being safer for the heart in terms of clot risk. We talk about overweight or obese women. I hate using that expression. I'm sorry. Gives a higher risk for breast cancer because fat tissue makes estrogen. So therefore, again, estrogen, progesterone slightly increases the risk of breast cancer. That needs to be discussed with a patient. Menopausal hormone therapy works well in overweight women for hot flashes, for night sweats, for vaginal dryness, for bone protection. So evidence also suggests that overweight women may report fewer hot flashes before starting therapy. So therapy is also going to be more effective for them because they're going to have less hot flashes. They're still going to have quality of life issues. So hormone therapy is going to be effective. So menopausal hormone therapy is not immediately dangerous. Their risk factors should be evaluated. Transdermal is preferred to use the lowest dose, and you have to pay attention to blood pressure, blood sugar, cholesterol, and family history.
Okay, thank you. Appreciate it. All right, Dr. Switzer, we will turn to you now. Is it normal to experience painful menstrual cramps post-menopause?
So again, we'll define menopause a little bit later, but we define menopause as 12 months without a menstrual period. And typically symptoms that you have at the time of menses, including cramping and bleeding, will stop after menopause. That being said, pelvic pain in women is a very complex symptom. And if you're experiencing abdominal or pelvic pain after menopause, that could be related to some other condition that may be going on. There's so many organ systems that are presenting as pelvic pain. That includes your bowels, your bladder, muscles, nerves, as well as obviously the reproductive organs, including the uterus and ovaries. So if you're having chronic or intermittent pelvic or abdominal pain after menopause, you should probably be evaluated by at least your primary care doctor and a gynecologist. Your gynecologic care should not end at the time of your menopause. We should continue to see you so that we can screen for conditions like cancers and symptomatic menopause with an exam.
Thank you. All right, Dr. Rapp, is a hysterectomy recommended to prevent uterine or cervical cancer?
Yeah, so really only in rare cases. Hysterectomy is still a major surgery, even if it's done in a minimally invasive or such as robotically or vaginally, still a major surgery. Cervical cancer is really easily detectable in early stages as long as you're coming in to get regular gynecologic care with pap smears. So it's really never indicated to have a hysterectomy to prevent cervical cancer. Cervical cancer is not genetic. So your risk is your risk. It has nothing to do with your family. It's really related to HPV, which is something that each person has their own exposure history to. And it is actually a sexually transmitted infection. The times when you would think about a prophylactic hysterectomy is really just in the case of certain types of genetic predisposition. So if you know that you carry something called Lynch syndrome, so that's a predisposition, not just to endometrial cancer, which is uterine cancer or colon cancer, then you can have a pretty high risk of developing uterine cancer, and that will be a reason to have a hysterectomy. Same thing as far as ovarian. If you carry one of the BRCA genes, it's a good idea. And again, this is obviously shared decision making with your provider as far as timing, but certainly to have your ovaries out and sometimes to have a hysterectomy at the same time if you carry one of those genes. If you don't have one of those genetic predispositions, there's of course other indications for hysterectomy. So if you have really troublesome bleeding that's not responding to medical interventions or other medications, or if you have uterine prolapse, those are other indications for hysterectomy. But in general, it is a major surgery and it's not recommended for low risk women without symptoms because the potential risks can really outweigh the potential benefits.
Okay. All right. Thank you. Okay, Dr. Clemens, what are the alternatives if you cannot take estrogen due to stroke risks?
So I'd first like to just start off with making sure that we review the contraindications in general to taking menopause hormone therapy or systemic estrogen. So that's going to exclude vaginal estrogen creams or tablets. Many of us as OB/GYN physicians, menopause specialists, we're going to look to the Menopause Society's 2022 position statement, which is like a consensus guideline or practice bulletin for menopause care and hormones. So they list the contraindications for oral and transdermal hormone therapy would be unexplained vaginal bleeding. So like what Dr. Rapp was just talking about, or what Dr. Schweitzer was just talking about, was you have unexplained bleeding pain that needs to be evaluated prior to start of hormone therapy. Liver disease, prior estrogen sensitive cancer, prior coronary heart disease, if you've had a prior stroke, if you've had a prior heart attack, or a blood clot that would be in your lungs or your legs. Or if you have a personal or inherited high risk for thromboembolic, which means clots type of disease. A great patient resource that I frequently, probably daily, whenever I'm seeing menopause patients, will talk to them about if we do need to discuss alternatives to systemic estrogen therapy is outlined in the Menopause Society's meta note that's called like non-hormone treatments for hot flashes and night sweats. Many of us use this frequently as a take-home for patients so they can review what we've discussed. It reviews a whole list of options that have been specifically clinically proven with statistical significance in studies to reduce the vasomotor symptoms when they do clinical trials and they compare it to placebo. So it's a kind of a long list, but just to focus, there's clinical hypnosis, cognitive behavioral therapy. Most of the patients also want to talk about the different alternative medications. So fezolinetant, which is, people will know it as Veozah, is a neurokinin B antagonist that works in the brain to reduce your vasomotor symptoms. Gabapentin, which a lot of people may know as Neurontin, is a medicine that has been used for seizures and nerve pain. It also has been shown to help vasomotor symptoms, and it's often taken at bedtime because it does make you a little bit sleepy. So some of these things we think about additional symptoms that are bothersome to patients when we think about which one to choose. Oxybutynin, or it's known as ditropan, that's something we have traditionally used for overactive bladder or urgent urinary incontinence. It has some side effects, but it also has been shown to decrease vasomotor symptoms. And then the last type of medication that I think many of us are often talking about because we notice the mood changes during menopause and perimenopause are very common, but SSRIs and SNRIs have been shown to decrease the vasomotor symptoms. And so SSRIs, you may know, it was like Paxil, Celexa, Lexapro, and then there's the SNRIs, which are like Effexor and Pristiq. And sometimes they're even used in lower doses than the traditional doses for anxiety, depression symptoms. But if the patients are truly having those symptoms, then often we'll be using them in the traditional dosing to both potentially help the vasomotor symptoms, but also with their mood changes. There's also some research for stellate ganglion block. I don't think many of us have ever probably heard of it, let alone used it, but essentially, it's nerve blocks that are done in the neck area, but it has potential risks, so we don't really see this use much. And then studies have shown that for women, that weight loss can potentially reduce their vasomotor symptoms. Thanks.
Thank you. All right, very helpful. Appreciate you walking us through that. Okay, Dr. Faye, we'll go back to you now. Next question here. What do we do to help boost sex drive after menopause?
So sex drive is not just hormonal. It is deeply connected to how you feel about yourself and your partner. So emotional intimacy often fuels physical intimacy. Open, honest communication about desires, discomforts, and fantasies can reunite passion. Many women report low desire linked to more relationship dissatisfaction than to hormones. So it's important to connect and rebuild sexual connections by scheduling intimate times. Without pressuring for sex, trying new forms of touch and foreplay, exploring what feels good now, since menopause is now. So I always talk about different books, and some of my favorite ones are Come As You Are and Mating in Captivity. We also can look at medications because a lot of women at menopause are on new medications that they weren't on before. And some of these can decrease desire or increase desire. We also talk about using a medication that is not FDA approved, but we use it, which is called testosterone. Remember, when we are now decreasing our hormones, estrogen and progesterone, we're also decreasing testosterone. We use testosterone at 1/10 the dose of a male dose, and it can safely benefit some women, not everyone, but it's administered as a gel or a cream. And as I said, it's not FDA approved, but with consent, we can prescribe it off label, and unfortunately, it's paid out of pocket. It requires regular monitoring, and it's best for women who are diagnosed with what we call hypoactive sexual desire disorder, which means that you not just come in and say, I felt great last week and I had sexual desire last week and I have no desire this week. It has to have been going on for at least 3 months. And it will not prevent dementia. It will not cause breast cancer, and it will not cause uterine cancer. It increases desire, fantasy, more frequent arousal, satisfaction, and sexual responsiveness. The risks and side effects, if it's not monitored, you get acne, hair growth where you don't want it, hair loss where you don't want it, and mood changes. So many meds that we take on a daily basis can also lower libido, like the SSRIs we've talked about, and blood pressure meds. So we also have, and I talk to everybody about these too, we have great apps out there. And one of them is called the Rosie app, which is science-based wellness education, guided self-help programs, autoerotica tailored for women with live coaching. It encourages exploration of your own sexual responses and normalizes sexual changes after menopause. It gives tools to women to rebuild arousal and desire on your terms. And it's great for women who are either not ready for therapy or who are looking for discreet, flexible options. And it's meetrosie, ROSY.com, if anybody's interested. And also, remember, if you're stressed because you have sick parents, your kids are driving you crazy, work is hard, or just life in general, stress is a major libido killer. Also, chronic stress increases your cortisol, which suppresses your sex hormones and dulls your desire. So we talk about mindfulness and meditation, yoga, breath work, even 10 minutes a day can positively impact your libido over time. If your sleep is disrupted, it causes low energy. Who the hell wants to do anything if you're tired, right? Your mood swings, zero desire for sleep. We talk about a consistent bedtime, reduce blue light, stop the caffeine at night, consider melatonin, consider magnesium, cognitive behavioral therapy, and we address the night sweats. If all doesn't work, then you talk to either a sex counselor or you talk to a sex therapist. We'll help you feel connected to your body first and then your partner. If you're avoiding intimacy due to trauma in the past, pain, or shame, if you feel broken, you're not. This happens to a lot of women. And as therapists and as counselors, we help rebuild your desire and pleasure, working through shame or guilt, We help guide couples through intimacy after hormone changes, and we develop new scripts for arousal and connections. So I encourage everybody, talk to your GYN, talk to your PCP, or find someone online to help you. Live the life you desire, because this is what you need and what you actually not only desire, but you deserve, because we can help you.
Absolutely. Thank
So
you.
that's my lecture for the day.
Yes, we appreciate it. And those were some really great resources. So thank you for sharing those. I know a lot of people will find this helpful. Okay, next question here, Dr. Switzer. I know we talked about this a little bit earlier, but if you have anything that you'd like to add on here, talking again about what can be done about belly fat that, as we mentioned, sometimes diet and exercise just doesn't seem to help with.
Yeah, so I think I addressed the lifestyle changes that we recommend with regard to diet and exercise. And I think sometimes it needs to be a little more intentional than just sort of paying attention to what you're eating meal to meal. So sometimes something like a food diary can really help to make sure that you're getting the appropriate nutrition. Also, kind of meal planning, which again, this is a busy time of life. It's hard to do that, but making sure over the course of the week that you're getting all of those nutrients that your body needs during this time of life. And paying attention again to portion sizes, snacks, and how busy you are when you're eating. I'm going to sort of tap back into what Dr. Fay said about sleep and stress, which also can play a role in weight gain. So optimizing your sleep schedule, your sleep habits, reducing stress, practicing mindfulness, thinking about where the sources of stress are in your life and how you can adjust them during this time where you are focusing on health and longevity is really important, again, for overall health, but will also help with some of that weight gain. In terms of exercise, I mentioned the recommendations are for 150 minutes of exercise per week. Again, it's break it up into chunks. It's also really important for women in menopause to focus on building strength. Like we talked about, we're losing muscle mass and we need to really intentionally build it back up. So while many people are used to going to the gym and doing cardio, it's important to add in some resistance training throughout your exercise. And that can count for those 150 minutes that you're doing for the week. So you don't need to add it on top of 150 minutes of cardio. We're sort of changing the way that we exercise as we move through this phase of life. By building muscle, maintaining muscle, you're going to maintain that caloric expenditure that's happening as you are living your normal life. So focusing on strength training. You don't need a personal trainer. There's lots of apps and videos on YouTube and things that you can do to help with that. Finally, I'm going to move on a little bit to just some of the adjunctive measures in terms of managing weights. People often ask me, well, if I take estrogen, is that going to help me get rid of this belly? And the answer is not really. Maybe there is a small benefit, and I think mostly it's because you're probably sleeping better. You're feeling better overall. Your emotional regulation may be better, and so you can stick to your lifestyle changes a little bit easier than you may have been able to without that estrogen menopause hormone therapy. There may be some small changes in terms of the fat distribution or with the ability to build some muscle, but like I said, some of it is simply aging and isn't related to the hormonal changes. There's been a few questions in the chat, and I know it's certainly a hot topic about anti-obesity medications, and this is somewhat controversial, and there's certainly a big benefit in terms of obesity and treating diabetes. But these medications also have not had long-term studies when used for weight loss in menopausal patients, and so we need to be a little bit careful about how we're using them. I think in our menopause program, none of us are prescribing these, but we do work closely with the Jefferson Weight Management Center. And the folks over there have access to nutrition. They do prescribe anti-obesity medications for which there are many, not just the GLP-1s. But those medications are meant for long-term use. And when people take them, they do see significant weight loss. However, when they stop them, that weight will return. So it's important while maybe using that as a tool to initiate some weight loss, or certainly if obesity is an issue, diabetes is an issue, those are great medications for that. There still needs to be lifestyle changes that occur to help sustain that weight loss over the long term. As I said, Jefferson Weight Management Center has lots of other resources as well. And so folks who may need other weight management resources like surgery, we also offer those services here at Jefferson.
Okay. All right, thank you. And thank you for mentioning the chat. I know that your questions have been coming through, so thank you. And if you have any additional questions that pop up, feel free to submit them in the chat. We will get to them in just a bit for the live Q&A, but for now, we'll continue to go through the rest of our submitted questions. Okay, so with that, I will turn to Dr. Rapp for this next question here. Is there anything that can be done about brain fog?
So brain fog, while distressing, is really a common symptom of menopause. Again, about 40 to 60% of women will report this during the menopause transition, and it's different for everybody. So for some people, it can be difficulty with word finding, inability to focus, hard to concentrate, feeling distracted. Declines in estrogen can contribute to these symptoms. Everybody thinks about pregnancy brain. Your brain is getting used to different levels of hormones, and that takes some adjustment. Sometimes the menopause symptoms themselves can contribute to brain fog. So if you're having hot flashes and night sweats and it's keeping you up all night, and then you're exhausted the next day and you're fatigued, you're of course not going to be able to concentrate or focus or do your normal, everything at work. What's important to mention is that brain fog, while scary, is often self-limited. It typically resolves on its own in a few years, and it is not an indication of dementia. There are studies of women that actually go through early menopause. So in those women, and if you are 43 or younger and going through menopause then, it actually does show that hormone therapy can reduce your risk of developing dementia later in life. There's a lot on social media. There's actually nothing that has been shown that women that go through menopause at a normal age or have any dementia reduction by taking hormone therapy. And actually, if you're 65 and older and you start hormones at that time, there actually can be a negative effect on cognition. There are other things you can do that actually help with your cognitive health. And that's things a lot like what Dr. Switzer has mentioned, eating a good diet, getting moderate intensity physical exercise, avoiding things like smoking, limiting excess alcohol, as well as monitoring and managing your chronic conditions, things like hypertension, diabetes, and cholesterol. The other thing that's beneficial, engaging in social activities, keeping those social networks strong, learning new skills. Those are all good ways to kind of challenge your brain.
Okay, so great pieces of advice there. Thank you. All right, we the next question. And Dr. Rapp, if you don't mind just putting yourself on mute, I think there might be a little bit of an echo. Thank you. Appreciate it. All right, Dr. Clemens, what kind of support is available for managing hot flashes?
So if we think about supports or other interventions that may benefit our health in many ways, these interventions may not have necessarily been recommended by the Menopause Society for vasomotor symptom relief. The reason is either that there have been some studies that have conversely showed that they didn't reduce the vasomotor symptoms, or maybe there's just not enough studies to show evidence that they're effective for vasomotor symptoms, but just to talk about them anyways, because many of them have other health benefits. Acupuncture has been discussed. There are supplements and herbal remedies, cooling techniques. There are ways to try to avoid the triggers of hot flashes and night sweats, discussion of some dietary modification, exercise, such as yoga, for example. People use mindfulness-based practices or interventions and relaxation techniques. There are cannabinoids. There's calibration of neural oscillations and chiropractic interventions. There are some medications that used to be listed as recommended, such as clonidine or pregabalin, which have had further studies that really haven't panned out for these to work well for vasomotor symptoms. I want to circle back to supplements because I know a lot of people often have questions about this. The problem with supplements and our ability to really recommend them is most of the studies on these are quite small. or maybe they're not well designed, or they may have a high risk of bias within the study because they're run by the people who are making these supplements. So currently the US doesn't have any supplements that are officially recommended by the Menopause Society or American College of Obstetrics and Gynecology. And, I often in my earlier years would say, well, but, we do have studies that show that there's tremendous placebo effect to some of these supplements, but we do have to approach that with caution, because just because you feel better and it may be a placebo effect, we do have to consider risks. So there are risks of liver toxicity to some of the supplements when they've been studied. So turmeric and curcumin have been shown to have some liver toxicity in certain dosing, as well as green leaf tea extract, black cohosh, and some things that are called proprietary blends that are within supplements. There's some lower risk with liver toxicity, but still could be present for herbal supplements like ashwagandha and Garcinia Cambodia, and then red yeast rice. So, one thing you can do if you're going to use a supplement is try to look for the ones that say that they've had third-party testing, which is going to hopefully give a little bit more of a layer of security that you are getting what you believe to be buying.
Okay, thank you. That is really helpful information for people to keep in mind. And I think that's a nice segue into our next question here for Dr. Fay. Just talking a little bit about natural remedies to support menopause, and if there are any.
I mean, actually, Dr. Swisher did a beautiful job, because really when women prefer to avoid or minimize hormonal therapy, they're really, the things we talk about: lifestyle, daily habits, regular exercise, aerobic and strength training, which has already been discussed, can improve mood, sleep, hot flashes, bone health, heart health. Dietary adjustments, really, we talk about plant-rich diets with whole grains, fruits, vegetables, lean proteins, limiting alcohol, caffeine. Spicy foods may reduce flashes. Weight management, which has already been discussed beautifully. Sleep hygiene, which we talk about cooling the bedroom, layering the bedding, consistent sleep schedule, relaxation. And again, we're not going to talk about any herbal options, because we know that the studies don't pan out. They're not, a lot of them aren't safe. Mind, body, and stress reduction, cognitive behavioral therapy, mindfulness, yoga, tai chi, meditation, acupuncture can help. And really, those are the things we all talk about. So really, if a woman chooses to avoid, medication of any kind, it's really healthy living
Okay.
and all of the good things. Absolutely.
Thank you, Dr. Fay. Okay, next question here, Dr. Switzer. We talked a little bit about, I think Dr. Fay had mentioned this earlier, magnesium. Can you kind of go into this a little bit more? Are supplements like magnesium helpful if menopausal hormone therapy isn't an option, maybe due to breast cancer history?
So I think Dr. Clements did a lovely job sort of reviewing the data or lack thereof of supplements, and that was supported by Dr. Fay's comments too about what we have from the more natural or supplement standpoint, which really isn't much, and it depends on the symptoms, right? So there's some small evidence that magnesium may help with mood or with sleep and with bone health. But for the most part, women are able to absorb enough magnesium through a healthy diet. It is a mineral that's easily absorbed by the GI tract, and most people are not deficient in magnesium. Maybe if you have celiac disease or some other malabsorptive condition of the GI tract, you may need some magnesium supplementation, but otherwise a well-rounded diet provides enough magnesium for supporting the body's health, and particularly bone health, which is one important feature of magnesium in normal physiology. I think the important crux of this question is about what do we do for patients with breast cancer when they've heard that they cannot take hormone therapy. And that really depends on the individual symptoms. And I think we have a whole nother talk about that, another question about that a little bit later. But there is hope for people who have a history of breast cancer that there are things we can do more than what magnesium could provide.
Okay, great. Thank you so much. All right, next question, Dr. Rapp. We will turn to you now. Can menopausal hormone therapy be used strategically for heart, bone, and brain health, even without other symptoms?
Right. I'm so glad somebody asked this question because I think that's one thing we haven't really talked about much yet is bone health and osteoporosis. And so that's actually one of the approved indications for hormone therapy is for bone protection. So this doesn't mean that it is a treatment for osteoporosis in and of itself, but especially in higher risk women, this can be an important reason to consider taking hormone therapy. You lose bone at the fastest rate, actually, in the years prior to your final menstrual period, and then in those, years immediately afterwards. And so, since DEXA scans often aren't done until years after that, by the time you have that first DEXA scan, you may not know that you have osteoporosis. So, it's certainly important to look at the patient and what all the different risk factors are when we're making the decision about starting hormone therapy. So, some common risk factors for osteoporosis are family history. So, family history of osteoporosis, family history of a fracture. And I mean an osteoporosis fracture, not you're in a car accident and you break your pelvis, but if you have a broken hip, if you have spine fractures, having a thin frame or a low BMI is a risk factor for osteoporosis, having an earlier menopause. If for some reason you're taking chronic steroids, which could be from autoimmune disease, if you have thyroid disease, if you have rheumatoid arthritis, if you have celiac disease, if you're a smoker, if you consume excess alcohol, all of these things can increase your risk for osteoporosis. So if you don't have other contraindications to hormone therapy, that may be enough in and of itself to start. While hormone therapy can have beneficial effects cardiovascular on things like lipid profile and reduced risk of diabetes, in and of itself, it is not an indication for hormone therapy for cardiovascular risk reduction. And actually, in women, if you start it, after age 60 or more than 10 years from menopause, there actually can be an elevated risk for cardiovascular events. I think I did address the brain health part of this with my last question about the brain fog. So in general, no, it's not recommended to protect cognitive health unless somebody goes through an early menopause.
Okay, thank you. Very
Yeah.
helpful. All right, we will turn to our next question here, which I think is an important one. Dr. Clemens, how does one know if they need menopausal hormone therapy?
So there are certain categories of women that truly need hormone replacement therapy, and I'm going to go over those in just a second. But for the rest of women that need menopause hormone therapy, it's based really on if the symptoms of the perimenopause phase or menopause are affecting their quality of life. And we don't specifically go by lab values in this scenario. So there are women who need hormone replacement therapy, and that would be recommended for women who either have primary ovarian insufficiency. That's when their ovaries don't make enough estrogen and have a much earlier menopause phase. If they are born with hypogonadism, which means like ovaries that are underdeveloped, so not making enough estrogen, or if they have surgical menopause, which is a terminology just referring to women who've had removal of their ovaries at an early age. Obviously, there are various reasons that could be the case. To go back to primary ovarian insufficiency, this is 1% of the population. So 1 in 100 women would fall into this category. This refers to women that are younger than 40 years old who already have FSH or follicle stimulating hormone levels that are in the menopausal range. And that would be also with amenorrhea, which means no periods, and we would mean for at least a year's time. And that cannot be explained by other medical reasons. So, for example, polycystic ovarian syndrome would be ruled out. Thyroid dysfunction would be ruled out. Or obviously they would not have prior surgical removal of their ovaries. 90% of the time when we run into these patients, there's no specific medical reason that we can identify for why this has happened. But if there is an identifiable reason, sometimes it's a genetic reason, such as Turner syndrome. There are some autoimmune disorders or single gene defects that can cause this. And then there are young women who've had cancer or other serious illnesses who then require chemotherapy or pelvic radiation, which is going to put them at risk for primary ovarian insufficiency because it's going to drop their estrogen levels because of the dysfunction then of their ovaries after treatment. So when we say need, that's kind of why I'm focusing on that for need hormone replacement. And we do see benefits from that for that population. The American College of Obstetric and Gynecology puts out sort of practice bulletins, committee opinions, and they have a committee opinion on this, stating that if you have a woman that has primary ovarian insufficiency, so under age 40 for their menopausal state, that hormone therapy is indicated because it's going to help reduce the risk of osteoporosis. It's going to help with cardiovascular disease risk, urogenital atrophy, which means changes in the urogenital, the vaginal and periurethral area that can cause pain and discomfort or dryness. And, you know, overall, it's going to improve the quality of life of women who have this primary ovarian insufficiency and need these hormones.
Okay, thank you. All right, moving along here to our next question, as I know we have a lot of submitted questions to get through. Dr. Fay, we'll turn to you. What is the best treatment for vaginal dryness?
So vaginal dryness is really common and bothersome. And it's probably one of the most common things that people come in with. They come in with it even before menopause, probably perimenopause, people come in with it. And there are several natural and hormonal treatments. And I know Dr. Rapp is probably going to do the hormonal treatment, but there are non-hormonal ways and natural ways that can restore comfort and intimacy. So one of the big things as a sex counselor, I talk to people about, stay sexually active. Regular sexual activity with or without a partner, so even with the dildo, can increase blood flow and keep the tissues nice and flexible. Hydration and healthy diet, drinking water, eating omega-3 rich foods, flaxseed, chia, salmon can support the tissue health. Avoiding irritants like fragrant soap, sorry, but no bubble baths. You don't smell like a rose down there, and you're not using roses. Douching is not good. Perfume pads and liners can worsen the dryness. Avoiding different things that are going to irritate. So we talk about all the different soaps that people use in terms of their detergents also can cause irritations. When we talk about vaginal moisturizers, we talk about long-lasting hydration, and moisturizers are not for during sex. So they are to be used several times a week, even if you're not sexually active, to keep that moisture going. And so the common ones are hyaluronic acid, just like you smear it on your face, you use it down there. It becomes very expensive. Our vaginas are very expensive as we age, guys. And so base ones are Hyalogine, Reverie, and Hyalofem. So those are very common ones. You just check the different prices and which one's cheaper. Vitamin E suppositories, there's a small studies that suggest that they may improve our dryness. Natural oils like coconut oil, olive oil, jojoba oil can be soothing. I love aloe. And that's a great one that you can use with an applicator. And omega-3 supplements are also, there's some mixed evidence that can also support the tissues. And we have vaginal lubricants that we can use that are water-based. And remember, if they're water-based, they have to be pH balanced. And if it doesn't say pH balanced, forget it. And remember, vaginal lubricants are used during intimacy. So we have water-based, we have silicone-based. One of my favorite ones is Uberlube. And we have natural oil lubricants, again, the coconut, almond. And remember, you got to put it on him and use him like a tampon. The other things are lifestyle and natural support, like pelvic floor exercises can help increase the blood flow and muscle tone, yoga, stretching, mindfulness, lower stress, which can worsen which can help worsen and help with this sexual discomfort, acupuncture. Some people report improved sexual comfort and blood flow. And I know we're going to be talking about vaginal estrogen in another discussion, but we know that that's what's lost at menopause, and that's what the American College of OBGYN, the Menopause Society, and the American Urological Association all agree is safe to use. It decreases vaginal dryness best. It decreases the risk of asymptomatic urinary tract infections. And we also, use it in women. It can be used at any age. It can be used as a cream, a pill, a ring. It's all patient's preference and can be started at any age and used for forever. So there's no 10-year window with vaginal estrogen. We have safety data to support that it doesn't cause endometrial cancer and it does not increase the risk of breast cancer or the recurrence of breast cancer. So we have a lot of options. So please talk to your provider and get some help.
All
I
right.
feel like I'm always talking.
It's extremely helpful. We appreciate it. Thank you. Okay, I'm going to jump around a little bit here for the last few questions, just so we can make sure we're getting to our live questions. So, Dr. Switzer, I will go to you next. How does one know when they are officially in menopause and how long it lasts?
Yeah, I think this is a good question and sometimes a little tricky. And I see some questions in the chat, but the official definition of menopause is 12 months without a menstrual period. So we can't make the diagnosis until we're able to look back in time 12 months and say, yep, you haven't had a period and you are now menopausal. That being said, I think you've heard from us all here tonight that this is a phase of life and a transition. So it's not just a one-time, you have it, now you're done. This is a symptomatic period of a woman's life that can, in the perimenopausal time, around that time of that last menstrual period, can last anywhere from 4 to 10 years of being truly symptomatic from this, and sometimes even longer. It's a very individualized experience for patients. For people who've had their uterus removed for some reason, a hysterectomy is removal of the uterus, or if they have a progestin IUD, or if they've been taking some sort of hormonal birth control pills continuously so they don't get a period for many years, this can be a challenging diagnosis to make because you don't see a period. So oftentimes we're asking about the symptoms that we've been talking about today. So are you having hot flashes, night sweats? Are you having difficulty sleeping? Do you notice a change in your mood? Are you noticing any weight gain, joint pain, brain fog? A whole host of symptoms. And there are lots and lots of symptoms that affect people differently. I hear things all the time, palpitations. It's very, very individualized. So sometimes it's a little bit hard to know if you're in that category of folks who's had their uterus removed or has an IUD in place, which we like because it helps us with our hormone therapy management sometimes. But officially it's 12 months without a period.
Okay, perfect. And Dr. Switzer, I'm actually going to follow up here with another question for you. As I said, we're skipping around here at the end. When should one start and stop menopause hormone therapy?
So again, there's no one size fits all for this. And that's why we actually love doing this, because we get to talk to you, spend time with you, understand what are the symptoms that are bothering you and what might be the right solution to help you with your health, longevity, and wellness over this next phase of your life. So it's really important for patients to find a doctor that they can form a relationship with. Your needs may change over the period of your perimenopause and your menopause. And so finding a doctor who can help you with that is really important. Typically, I'd say we're starting hormone therapy in the mid to late 40s in the perimenopausal period. And up into the 50s, we can be starting hormone therapy. We really want this to be initiated within 10 years of the final menstrual period and less than age 60. That's where the safety window is in terms of balancing the risks and the benefits of the therapy. So starting it in that window, and it's not one size fits all. It doesn't work the same for everybody, and one individual's experience is not the same as another. So good idea to talk with your doc. In terms of duration of therapy, again, there's no official cut point. We don't say once you turn 60, once you turn 65, you have to stop your hormone therapy. That's not true. And it can be challenging sometimes when people have heard different things. And I know I saw at least one person in the chat who is outside of the typical window of safety. And it's very frustrating to be in that category of folks. Like, did I miss my opportunity? And unfortunately, once you're past age 65, some of the changes that have occurred in your heart and your blood vessels make the risk-benefit ratio different, and there is a higher risk of initiating hormone therapy at that time. So that being said, it's, again, a good idea to meet with your doctor regularly check in on your overall health, particularly cardiovascular health, your cancer screenings, what else is going on with your health, and see if hormone therapy is still the right choice for you. And at some point, you and your doctor, through shared decision making, may decide that it's time to stop, or you may decide to continue for the remainder of your life. Again, it's an individual decision, and one that's informed by your health with your doctor.
Absolutely. Okay, thank you. And for our last submitted question here before we turn to the live questions, Dr. Clemens, if you don't mind just kind of discussing briefly, what is perimenopause? I know it's been mentioned, just want to make sure we're actually defining it.
Sure, I'm glad you asked that way, because that was the direction I was headed. Just the term perimenopause just means around menopause, which is really like ill-defined, right? So typically we'll say that once your cycles start to become irregular, meaning the cycle length is going to vary more than, say, 7 days from one cycle to the next. Maybe you're skipping a period, or just the cycle length is varying significantly. This can also be accompanied by other menopause-related symptoms, which I know we've gone over. Or there are women that still have regular menstrual cycles without that variation, but they do have already hot flashes, night sweats, brain fog, those symptoms that we've been talking about. And then, as we just said, this goes on for quite some time, and it really doesn't officially end until you have not had a period for a full year. So perimenopause goes all the way up to that time point where we say menopause, and then you become postmenopausal. So these years of perimenopause are typically the most symptomatic, and the reason is because your estrogen levels are going from your typical level to even higher than typical, then they're going to be even lower than usual menstrual cycle levels. And this can fluctuate wildly month to month, even like day to day. And that's why if you come and see menopause specialists, we're not just checking like your estrogen level during perimenopause, because this really doesn't give us answers. We really want to focus more on what's going on with your cycles, what symptoms that you're having. So this is why you'll see us not just checking those hormones. We'll often get patients that maybe their primary has already done this, and they, feel like befuddled that like this wasn't the answer to just do the labs. But, we're very happy that they end up coming in to talk to one of us or their OBGYN in general about these symptoms. So, just trying to be encouraging that, come in and talk about your perimenopausal symptoms, because there's quite a few different options that we can provide you, whether it's just adjustment of what you're using for contraception to tailor it to something that's going to potentially work better for your perimenopausal symptoms, or potentially starting a new medication in this phase of life.
Okay. All right. Well, thank you. And with that, I want to go ahead and turn to the live questions before we wrap up tonight. So I will go ahead and read the questions. And whoever wants to jump in, feel free. Definitely just meant to be an open dialogue. Okay. The first question here. This person says, are skin issues a side effect of menopause? My skin feels like it's burning off my arms. There's no rash or evidence of a skin issue, but the itchy burning sensation is horrible. So if anyone has any thoughts there, feel free to chime in.
I mean, there's so many different symptoms that can be from menopause, and that absolutely is one of them. I had a patient last week who had so much itching. She'd seen allergists, she'd seen dermatologists. Nobody could find anything wrong. She also was in the appropriate age and had some menopause symptoms, and we started her on hormone therapy, and her itching went away. So again, that's a case of one. It's not that it's guaranteed to work for everybody, but there are estrogen receptors in every area of your body. And so you can see skin changes, hair changes, nail changes, everything related to hormones. So yes.
Okay, thank you. All right, this next question here, I'm actually going to direct it to Dr. Fay. This question, what can be done for painful intercourse? Oh, and I think you're on mute.
Yeah. We would examine you first and see whether it is a matter of dryness first. And then I would honestly, because I would do a muscle exam and see whether there is issues with your pelvic muscles and look around and make sure that there are no skin changes to determine whether there's no dermatologic I would do a dermatologic evaluation. I would check for atrophy. I would check for dryness. I would do a muscle exam, and I would have to ask you more questions because I would want to know, is this a long-standing thing that you've had, when you were not postmenopausal? Did you have issues with exams? Did you have issues with tampons? Did you have issues with, is it with penetration? Is it just on outside pain? Is it inside pain? Where is your pain? So there would be a thorough exam to try to figure out, where is your pain with intercourse? Is it, upon initial penetration, deep penetration? So there would be more to the exam because, we'd want to know, because when somebody says that they're having pain with intercourse, you always want to know whether it's initial penetration or deep penetration, and want to know by exam from the outside in what's going on. So there would be a thorough exam to know what's going on. It's
Okay.
not always just dryness.
Absolutely. I think a reminder to go talk to your provider. So thank you. Okay. Next question here. If a woman has never had children, does that impact the type of hormonal replacement she would be eligible for?
Now,
Good.
one's obstetric or fertility history does not impact what your choices are for menopause hormone therapy or treatment during menopause.
Okay. All right. Thank you. Next question here. What can be done about hair loss during menopause?
I would start with first we need to evaluate other sources or reasons for hair loss because sometimes we just throw it in as a associated symptom of menopause, but we do need to rule out things like changes in this age group for thyroid is common. Anemia, mild forms of iron deficiency is more common than most of us realize. So you may see us checking not just a regular CBC for a hemoglobin, but we'll do some iron studies to make sure that there aren't other reasons. And we also need to know the history of it. I mean, some people also have this for other hormone reasons, such as polycystic ovarian syndrome, for example, or other medical reasons. And then
Or stress, right? Or stress.
stress, just like we see in other parts of our life. Um, sometimes we need a dermatologic evaluation as well. There are some medications that sometimes are used for hair loss once we rule out all of the other reasons, like minoxidil, that's either a topical or an oral. Some of us do consider prescribing these ourselves. Often we're also getting a dermatology consultation at this point and getting their opinion.
Okay, perfect. Thank you. All right. Next question here. What's the difference between hormone therapy and B hormone therapy? And are there less risks or side effects with B hormone therapy?
So I think when this person's saying B hormone therapy, they're assuming bioidentical hormone therapy. And so that is really one of the tools that we have. You heard, I think, Dr. Fay say, in general, a lot of times we go to an estradiol patch, an oral progesterone or prometrium. And so that is really as biosimilar to the hormones that your own body and your own ovaries produce before menopause. The advantage to doing this through a program such as this is that they are inexpensive, they're generic, they're FDA approved, so you know that you're getting something that's consistent. There are other places to get menopause care. We know that. And so sometimes those may be touted as safer or better, but they're really not. And a lot of times some of those other areas are kind of preying on you and things are much more expensive, trying to have there was some questions about blood levels. Really, for the most part, we all want to know how you feel. And so that's going to tell us more than any blood test. I'll say to people, if you're on thyroid medication, you want to be above a certain number and below a certain number. When you're on estrogen, progesterone, it's really more what symptoms you're having and how you feel. And that's kind of what guides us better. And so, yes, we often start with the bioidentical, but there are certain, each person is different. And there are some people that actually do well with different types of estrogen and progesterone.
Plus the fact that we have studies to show that our medication is safe, and we have evidence-based medicine where the bioidenticals don't have any proof that theirs is any safer. Then they can't tell you that there's consistency in the making of 1 month to the other, because there's not that FDA approval.
Can I just add a small point of clarification? Because the words here are confusing, but they're really important. And I think that sometimes on social media or in other types of settings where menopause care is being provided, the terminology is used more as a marketing term than what it actually is happening. And part of the history of menopause care is sort of important here. So there was a big study that occurred. It scared a lot of people, and this was in the early 2000s, called the Women's Health Initiative. And then many people stopped providing hormone therapy in a traditional medical setting and stopped teaching it to their trainees. And so there was a big gap in the learning for OBGYNs and all of the other doctors that might care for you, including your primary care doctor, cardiologist, neurologist, other doctors. And then an industry was born because women still had their same symptoms. They still had hot flashes, night sweats, mood changes, vaginal dryness, painful intercourse, don't want to have sex. All of that drove an industry to create quote unquote bioidentical hormones that are sometimes injected into the skin and that are non-FDA approved and can be really dangerous actually for women because they aren't processed the way that we would expect normal medications to be processed when they're implanted in the skin. Now that we have more evidence and more choices in our pharmaceuticals, which include, I liked what you said, Sandra, was I forgot what you said that wasn't bioidentical, but biosimilar
Biosimilar.
yeah, biosimilar to what is produced in our body, but through actual labs with safety data that's associated with that, we can give you the same type of medication covered by insurance that people were looking for when they were trying to find an alternative to the traditional menopause hormone therapy that went out of favor for some time.
Okay, thank you. And I think that's really important background information to keep in mind, and helps paint a little bit of a better picture here. So thank you. Okay, next question here. We have a few more. No, we're nearing the end, so we'll see how many we can get through. One more question here. Is heightened anxiety a symptom of menopause? And what are good ways to address it, if so?
We talked about mindfulness. We talked about yoga. We talked about just trying all of the natural things that we talked about in terms of calming someone down, in terms of for hot flashes and night sweats. They also work for anxiety. So it's just, again, all of those Tai Chi, acupuncture, all of those natural things, again, are again helpful for anxiety too.
Thank you.
I would say there
anything
are
to think
times
of. Yeah.
that hormone therapy is helpful with anxiety as well. I see that especially in the perimenopause time. So when the hormones are fluctuating, the periods are fluctuating, everything is fluctuating, especially if you're someone that's had some mental health issues in the past, whether it's related to pregnancy. We can see that come up again around the time of menopause. So that to me is more often a perimenopause symptom. If you're 5 years past your last period and develop new onset anxiety, that's usually less likely to be something that is menopause related or would respond to hormones, because by then there's not that fluctuation, which is really more of the trigger.
Yeah, it's when perimenopause, when your hormones are like a lava lamp. It's horrible, and it can be really the hardest time. And it's really tough on your body. It's tough on you emotionally. It's tough. It really is.
All right. Thank you. Okay, next question here that I want to get to. Should we be doing hormone therapy even if we don't have any symptoms? Should every woman be taking estrogen to support our estrogen decline?
I think, the easy answer is no, because, if you don't have the symptoms, you don't need to. There's not a requirement, health-wise that you need to be on menopause hormone therapy. However, if you're not going to be on this medication, you do need to realize right around the time of menopause and that year or so after that there is a steep decline in your bone density and that you really do need to take into account or use other measures to try to keep up with your bone health. We always say weight bearing exercise, but specifically studies have shown using hand weights is specifically helpful in making sure you are mindful of getting that calcium and vitamin D in your diet that you need to.
Okay, thank you. All right, next question.
Sarah, but I always stress to people that when you're talking to them, they don't have to make the decision right away, that we're not car dealers, that it's not like if they leave, they have to make that decision right away because the option's going to change. That if they don't make it right now, they have to worry that they can always call us back in 6 months. If their quality of life changes, they know what the symptoms are, they know how they feel now. If they need to reevaluate and things change and the flashes get worse, their moods get worse, their joint pain gets worse, things get worse, they can always call us back. They have that 10-year window. They don't have to make that decision that day. But they know what they're looking at, they know how they feel, they can think about it. It's not something that has to be made that moment.
I think that's a really important reminder. Thank you. Okay, I'm going to say the last question here because I have one final question that I want to ask you all before we wrap up for the evening. So, last question. If you start hormone treatment and then you need to go off for whatever reason, will your symptoms return? And Dr. Switzer, I see you nodding.
They could, they could, they might not. I mean, I don't think there's any guarantee. I don't think anybody can guarantee that.
Yeah, and I think it depends on when and how and individual patient experience. But yes, it's possible.
I mean, I have a woman who hasn't gone through menopause yet, and she's 74. And she's not having a hot flash or a night sweat, and she's still menstruating normally. And that's her whole family history. Everybody goes through it late, and she's not having a symptom. So there are women who 25% of women don't have symptoms, 25% of women have every symptom in the book, and 50% of women have have symptoms. So I think everybody's different. So some people, you give them enough and they stop and they're fine. I don't think there's any way that anybody could tell you if you're going to have symptoms or not if you stop.
Okay. All right. Well, thank you. And with that, I want to go ahead and ask the last question for this evening. And that is, what are your goals for everyone listening in on this webinar? What would you want our viewers to take away from tonight? And Dr. Faye, we'll go ahead and start with you.
I want people to feel empowered to ask questions. I want them to find practitioners who are certified, who will be supportive of their needs. I want them to know where to seek help, normalize the discussion of their mood swings, their libido changes, their sexual function. We're here to help. We want women to feel that there are practitioners out there who care and listen and are here to validate their feelings. I want them just to find the right people.
Absolutely. All right. Thank you. Dr. Switzer?
Yeah, I agree 100%. And as the resident program director in the room, I do want to acknowledge that there are many well-meaning doctors of all specialties out there who just did not get this type of education. And so that's really hard for patients when they're coming in with a problem or a set of symptoms that they need help with and it's not recognized, and that can feel really hard. So Please know that we're working on improving education for medical students, for residents, and that there are a lot of doctors who are available to help you who are knowledgeable about this topic. One of the great resources, I think we mentioned it already, is the Menopause Society website. And on there, you can search for a menopause certified provider. So if you are visiting us from someplace not conveniently located to Jefferson, there is a way to locate other menopause certified providers in your area, or if you're talking with friends. We know how important networking is and communication for women. So tell your friends, and that's a great website to help people identify someone who can help them with this time of life.
Yes, thank you for that reminder of that resource. Okay, and Dr. Rapp, any final remarks from you?
Yeah, I'll build a little bit on what others have said. So first of all, also on that menopause.org website, and Dr. Clemens mentioned also, you can search for MenoNotes, and there's lots of really good, just free patient information that's accurate, gives you a lot of different options out there. And the thing I really want to say is just like everybody has their own personal experience of menopause and symptoms, there's not a one size fits all treatment. So I love when people come to the office educated. I like when you've done your research and have ideas. But I want to say also just kind of be open to suggestions. Sometimes there are things that we know of that you maybe haven't heard of that might be the right fit for you.
Thank you. Okay. And finally, Dr. Clemens.
Thanks. It's hard to go last after all of the great comments about, what we'd like everybody to take away. I was planning to say something similar to what Dr. Rapp just said. I really think this really isn't a one size fits all kind of situation. As you've listened through this whole webinar, there are different symptoms and different medical backgrounds and so many different factors that go into what makes the most sense for you at what phase you're at or what background conditions you may have or what your greatest concerns are. And the most important thing is really just getting in and talking to your physician. And if you don't feel like you're really getting the attention and the answers that you need, there are those of us that really want to put menopause care at the forefront of the care that we offer, and we're available.
All right. Well, thank you all. Thank you, Dr. Fay, Dr. Switzer, Dr. Rapp, and Dr. Clemens for your time this evening. We really appreciate you, taking time out of your schedule to answer these questions. And thank you all for submitting such great questions. I know I learned a ton. So we really appreciate you attending. We will be posting an event survey so you can let us know your thoughts. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars just like this one and more. A recording of this event will also be sent to you so you can rewatch at your convenience.